but if I can have your attention, because I am very proud to introduce nurse consultant Jo Fernandes, who worked with us at Michael Sobel till very recently. We all love Jo, as I know you all do too, those of you that met her. She is an extraordinary nurse, teacher and communicator, and has had a long interest in the ethics of assisted dying and how palliative care will be impacted if the law changes. So I'm really pleased to present Jo.
Thank you, Carol. It's really lovely to be here, so thank you very much for that warm welcome. And wow, well, you all ran away when it was my time up here, but I'm going to not take that personally. I've got a very short time to update you on what I'm sure you will all agree is a very topical subject right now. Where are we in terms of assisted dying? So what I'm going to do is just very quickly tell you where the bill is in terms of the assisted dying bill called the Terminally Ill Adults Bill in the UK, how that is progressing in Parliament in England and Wales. I'm going to particularly focus upon some of the impacts that we may now need to consider in palliative care. And then I'm going to ask for some respectful audience participation. To reassure you, I'm speaking from a position, as I always do on this subject, from neutrality. I'm not here to influence you either way, and obviously I'm hoping that we will be mutually respectful. But I am going to ask you to get your phones out at the end of my presentation, and we're going to do a couple of Slido questions, which I hope me and my colleagues at the back will be able to ease you through. My title, first of all, a bit of a nod to Simon and Garfunkel, for those of you, such as myself, old enough to remember that awesome duo, Troubled Water or Homeward Bound. I am going to suggest to you that we are now, in terms of the assisted dying debate in this country, out of the real troubled water whereby we had people who were at loggerheads. Should we, shouldn't we? Is this right? Is this wrong? Binary debates. That is not suggesting that there are not still people who will have very opposing views, ethically and morally, about whether we should have laws that entitle people to an assisted death. But what I'm saying to you now is those troubled waters of binary debate have now shifted to somewhere more homeward bound, whereby we are now in a situation of experience, of being able to learn from other countries how they have got it right, maybe where the pitfalls are. We have had commissions that have been able to inform our parliamentarians. We now are in a situation where we are in our own professional ways of thinking, able to draw upon some pretty robust evidence. So that's what I'm meaning by homeward bound. So very quickly, just to tell you where the assisted dying bill is right now. Interestingly, not called assisted dying. That in itself I could talk to you about for many minutes. This is the Kim Leadbeater Private Members Bill, which was last debated last Friday. And I'll talk you through the timeline in a second. But just ostensibly, what is this bill proposing? It is proposing in England and Wales a right to an assisted death for somebody over the age of 18 who is capacitous, who has a diagnosis of a terminal illness with less than a 6-month prognosis, who is resident in the UK, in England and Wales, registered with a GP, has a clear and settled intention to have an assisted death, and can evidence no coercion. Think this through in terms of what this might mean in practice. It is going to be a 2-doctor assessment, a coordinating doctor and a subsequent doctor who will be very involved with this patient, their families, and the process. There is 2 periods of 14-day reflection that is built into this bill. There is then a panel. Now, if you remember one of the first of the Kim Leadbeater bills, was proposing. The High Court got involved at that time. That was thrown out pretty early because it was deemed that that was not going to be possible and practical. But instead, there is this panel that will review every situation, every request. Then a certificate of eligibility is issued, followed by another period of reflection. And then the doctor, the coordinating doctor who has developed a relationship with this person, will be the person to give the drug that the patient themselves takes. This is not euthanasia, where the doctor ultimately gives the drug that ends the person's life. This law is physician-assisted dying. It's very much based upon Oregon. Kim Leadbeater and her team suggest this is the most robust bill that has ever been proposed in our Parliament. So where are we in terms of this bill in our Parliament? Last Friday, as I said, it had its third reading, and other amendments were then agreed. Crucially, it is this Friday, the 20th, which will have its final reading and vote in the House of Commons. If that goes ahead, it will then go to the Lords. Again, the same iterations in the Lords. If it is voted in favour in the Lords, it'll then go to royal assent and will become law in this country within the next 4 years. That is a long period of time. We still don't know how the parliamentarians are going to vote. It was a 50 MP in favour last time it was voted on. We know that some of those MPs are now thinking of voting against. However, 3 have said that they will vote in favour of the bill, having said they wouldn't last time. So we don't know which way this is going to go. What I'm, of course, asking all of us in palliative care to do now is, again, not think about the loggerheads, but think about if this is going to become a possibility, how are we going to work with this? Very quickly, last Friday, the amendments that were then passed was a clear prohibition on any form of advertising. So any private company or hospice or NHS service that will offer this will not be entitled to advertise. Health professionals will not be entitled to bring this up as an option to people under the age of 18, but they will be able to do so for those over 18. The coroners will not be involved. Again, this is around trying to make this as least process-driven but appropriately as possible. And as I say, I'm not here as a proponent. I'm trying to tell you the facts from a very neutral point of view. We don't know yet what substances, that's drugs, are being proposed. That has not been detailed yet, and there is concern amongst the medical profession and pharmacists about that. But again, what was voted on Friday was that some regulation around that, with the MHRA involved, will be necessary. Other people are concerned that that in itself will cause an awful lot of red tape. So that's where we are. So watch this space. It's Friday that this is coming. As I say, if that vote is a positive in favour of a change in the law, we're not there yet, but we will be further than we have ever been in this country, which is why more than ever, we as a palliative care, a health professional community, and indeed ourselves as members of our society, have to give this very, very due regard. Very quickly, you can have these slides that there are other places in the United Kingdom who are also progressing through their own parliaments, okay? Channel Islands, Scotland, and the Isle of Man. I'm not going to talk to you internationally because, again, I don't have time. The reason I'm bringing up Canada is because it's one of the more recent laws that back in 2016 it was changed. And maybe we can draw similarities around a country where there is adequate palliative care provision, one could argue a westernized healthcare. They went whole hog and legalized both physician-assisted dying and euthanasia. They arguably now, with Belgium, have the stretchiest laws of all. The reason I bring it up, because I think it is a good example of the nuance of these debates when we're now looking at evidence rather than just our own kind of gut feel. So For those who are in favour of the law, the fact that there has been an exponential increase in the amount of people accessing an assisted death, in particular a euthanized death, is a good thing. This is around exercising autonomy. This is around ending of their suffering. Maybe those who are more concerned about the slippery slope, the fact that Canada, within less than a decade, have 4.7% of all deaths are now assisted, and they have the highest number in the world, some people may consider that an area of concern that is up to all of you to think about. Or maybe, as many people sit somewhere in the middle of that with all of these things, there is context. The other thing, really, just to I suppose reassure you, because this is very important for us in palliative care, is that alongside state-funded assisted dying in Canada, there has been a very large increase in funding of palliative care as well. So there has not been this either-or scenario. And one needs to think about that in context of what may be coming down our tracks. For those of you who are very interested in this subject, to cut you out of a lot of reading, I do advise that you go to Inside Health or as a podcast on Radio 4 and listen to the 3-part debate, which was actually a few months ago now, or maybe last month. So it doesn't pertain to Friday or the most recent parliamentary things. But it's very, very informative on looking at many issues. And Professor Catherine Sleeman is a palliative care professor, and she is a very moderate spokeswoman on this issue. And what she has done is had a look at what the impact for palliative care may be. And I'm just going to very quickly go through some of the main points that she makes that I hope you will find important and thought-provoking. So with the government impact assessment, there was this big cachet around there is proposed a significant cost saving to us in terms of our NHS and social care and pensions over the next 10 years, over the first 10-year period of an assisted dying change in the law permitting assisted death in this country. Of course, there are some counter-arguments to that. Firstly, from a hospice perspective, we know that a lot of our funding is not state-funded. So if hospices are required or if they opt to get involved with assisted dying, could there be a negative impact for those people who would want their hospice not to be involved with this? That is causing some concern. The counter-argument to that, of course, is if this is what society wants, we need to do a bit what Canada has done, which is throw a lot more money at palliative care as well. But we know that's very easy to say, don't we? And we know that hospices and a healthcare sector and social care and so on is hugely stretched right now. How safe do we think is safe enough? This has been an argument that is still a really, really important one for us to consider. Okay? We always used to say that we stopped capital punishment in this country because we found it intolerable if we put one person to death who was innocent. There is still a concern around this issue of how do we absolutely safeguard, irrespective of how tightly written a law is, against tacit coercion. People who feel a burden. It may not even be overt, it's tacit. Now, in the bill, there has been a lot of conversation around the essential aspect of education for us all if this becomes law. And one of the main areas of education is proposed to be around training us all to detect coercion. Think about that. Do you feel that's something that you would be confident in? Going back to Canada, as I say, I'm trying to sit on the fence here, but again, we can learn from countries that are down this track that we may be going down. In Canada, if there were any main issues initially, particularly when it came to teams of clinicians getting together with opposing views and opposing levels of willingness to be involved in assisted dying, it was the fact that they felt insufficiently supported and educated. So if this comes our way, how are we going to educate our workforce? And as the Hospice UK, in their recent report, suggested, where is the money in the hospice sector going to come from this enormous piece of education that will be profoundly impactful upon getting this right if it becomes law for those who opt for it, but also getting it right for us, for the workforce, to protect us and to protect all of those potentially opposing views and willingness to participate. The issue of trust, yet again, is something that is considered highly problematic for some. What does it mean about hospices? Are they continue to be a safe haven, or does this change the dynamic? Some people will consider it changes the dynamic for the better if it is proposing a better adherence to autonomy. Your thoughts? Do we all feel confident to have these conversations with people? Again, that's back to the education that we are now going to probably really need to factor in should this become law. Suffering, again, is something that could take me too long to think about. But remember, this has been the bedrock of many of the arguments in favour of an assisted dying, that palliative care is not the panacea. And therefore, should there be a law that does, for those tragic minorities, end their suffering in a way that is not, unless there's an assisted dying law available to them. So this is an issue for all of us now. It is even more relevant on Wednesday when we have this vote coming on Friday. I hope that all I've done right now is given you a little bit of a feel for what is possibly going to come. Or even if it doesn't come, where are we then? So it's about compassionate end-of-life options versus robust safeguards. What I want you to do now is all grab your phones, and hopefully my lovely colleagues at the back, please remember that what I'm trying to do here is not put you in a situation of being at loggerheads. As I say, I'm hoping we've moved on from loggerheads now. But I would love you all to access that code and then answer these questions that may just be able to generate a little bit of discussion or questions in the Q&A session. So, when thinking about assisted dying, what words or phrases come to mind? And hopefully now things will start. We'll just give that a few seconds.
For those of you who haven't used Slido, just go to slido.com.
Oh, sorry.
Sorry, I should have explained that. Go to slido.com and then type in that number, and then you can just type in on your phone and all your words will appear.
And am I right that the larger the font, the more hits that's got, or is it just being pretty? Yeah, no. Just a couple more seconds and then we'll go on to, we've only got 2 questions, but thank you for everybody who is participating in this. I hope that you can see this in itself as a wonderful conclusion of this really important situation. Slippery slope. Yeah, so what we've got as the biggest in green is choice. Choice and autonomy. Peace, worry, concern. Interestingly, when it comes to worry, many years ago, probably about 20 years ago now, Ros and I were at an initial conference in London where the great and the good of the medical profession were arguing against the great and the good of the legal profession around assisted dying. And one very eminent physician said, the more I know about this, the less I understand. And I was very interested in something that a dear colleague of mine, texted me the other day and said, maybe now we're in a position, because we are more informed, about the more I know, the less I do fear. So that's an interesting thing around what maybe the international picture and research and so on has done for us to at least understand the situation we're in. Okay, impersonal, uncomfortable, scary, compassion, a two-tier system. There's so much here we can talk about, but I am very aware of the time. So I'm going to go on to my next question, if that's all right. What might the impact be on health professionals if assisted dying is legalized? So this is your opportunity to look around the room. This is your opportunity to think. Well, just to think. I won't tell you to think particularly. A loss of trust in us. Stress. Being sued by relatives. Really interesting point. Back to that issue of coercion, yeah? How does one absolutely safeguard against coercion? And just so you know that in 2015, the Maris bill that went through Parliament, it was the lack of safeguards around coercion that threw that bill out. So that it was a very, very significant concern. Kim Leadbeater has done all she can. She proposes, and she is very willing to work with the hospice sector and so on if this bill does go through. But again, do we know enough about how to mitigate against coercion? Division. Feel out of the scope of my practice. How often have we heard that? A lack of training, the fear and the guilt. Whoa, this is quite heavy reading, isn't it? A deep insecurity. Oh, goodness. Yes, absolutely. Stress again. True compassion. What if health professionals don't want to get involved? The bill is very clear that there will be conscientious objection, the right to every individual to conscientiously object. Again, if you're interested in that, there's an awful lot written in Canada that can both incite that anxiety more and allay it. Please do look at Canada. The Canada bill is called MAID, Medical Assistance in Dying, and there is some very good evidence that comes out of that. We need to support the law, absolutely. If this is something that, again, that Hospice UK and all of us need to consider very, very, very carefully, that if this is the law of the land, the society has a right to access that. Would wrong professionals. So we've got 8 participants still typing. The change of it would be chaotic. Thank you so much for participating in that Slido. And I think you've summed up this beautifully in terms of the opportunities that I am hearing some of you are feeling, choice, autonomy, but also some of this very important detail that if this becomes law, and it will be enacted, I think it's going to be 4 years, there is a lot of detail here that needs to be seriously scrutinized and planned for. So I hope I haven't frightened you all. I certainly hope I haven't imposed any opinions or offended any of you. I hope that you just feel a little bit more updated and you'll all be listening to Parliament on Friday. Thanks very much.
Thank you, Jo. I'm sure you'll agree with me, all of you, that we could listen to Jo talking all day. So I'm really sorry we only had a few moments, but please, I'm sure Jo will answer some questions later, and then we've also got lunch as well.